Hello everybody, my name is Haley Catron and today I'm going to be doing my presentation on the suicide rates in the active duty military. So to discuss the social validity of this problem, in the US, more than 300,000 people complete suicide each year. There were 111 more completed suicides in 2020 compared to 2014 in the active duty military. Here is a visual chart that shows you the completed suicides broken down by if they were active duty in the reserves or in the National Guard, and then total compared to each individual branch. As you can see, in 2014, there was 273 active duty deaths from suicides. In 2021, and in the first two quarters, there were already 174 completed suicides. So as you can see, this number is growing. In 2020, there were 384 completed suicides in the year total. Here is a graph showing the increase in number of suicides from 2014 to 2020. As you can see, in 2014, the graph is just above 270 active duty suicides compared to 2020, when it is closer to 390, as we just previously discussed. As you can see, this graph is increasing, which is not what we want this graph to look like. So why don't active duty military seek help? Mainly it's because the active duty military members fear seeking mental health help for many reasons. Some of these include the risk of their security clearance being revoked, not being able to be promoted, not being allowed to handle weapons anymore, and being seen as fragile or weak. In addition to these things, there's also a lack of confidentiality. Medical appointments for normal, everyday appointments, normal checkups, if they're injured, all have to go through leadership. The results in medical reports are also reported to leadership. And in addition to this, doctors have to give a referral to behavioral health, leading to a fear that the appointment will also be reported to their leadership, which they then fear would lead to all the repercussions that we just previously talked about. So from a behavioral analytic perspective, the function of not seeking treatment is escape. They are escaping the ridicule that they fear, and the repercussions that we already discussed. This is compared to attention. They aren't trying to get attention from this. They're trying to do the exact opposite of get attention. They're not trying to gain anything from not seeking help, and it's not sensory based. It's purely out of a fear of escape. From a behavioral analytic perspective, continued, the establishing operation for getting help is knowing they will feel better if they were to seek the mental health help, feeling a reduction in anxiety and agitation, and a possibility of improving their eating and sleeping habits. In abolishing operations for getting help would be the fear of removal of security clearance, not being allowed to handle guns, and fear of getting discharged, as we previously discussed. Skinner in 1953 discussed group control. Group control is at play with creating the stigma about mental health help. Groups label environmental stimuli as either good or bad. The good, according to the military, with talking about your emotions, is to not talk about how you feel and pushing down how you feel and just not having emotions. It's a very masculine environment, so talking about your feelings is not looked favorably on, so it's considered bad. Facing how you feel and discussing hardships in life are considered bad according to the military. So the proposed solutions for this, I have 3. Allowing service members to seek their own therapists, holding one-on-one meetings, and then leadership being more transparent about their own struggles. So talking more about allowing service members to seek their own therapists, this would ensure their confidentiality because these appointments would not be going through their leadership anymore. It also allows the service members to have autonomy of their own mental health, which would be beneficial, and it makes the service member feel more comfortable and at ease knowing that they were able to choose who they get help from. They can choose their own counselor, and they can choose, and they'll know that this information will be kept confidential compared to being seen by somebody on post that their leadership gave to them. Discussing the one-on-one meetings a little bit more in depth, I think these should occur at least once a month. During these meetings, they should discuss home and personal life and see how things are going outside of their careers. This would increase a trust in leadership, and it would also allow the leadership to gauge if the military member has a change in personality at all. Sorry. And then finally, leadership being more transparent about their own struggles. This would allow a level of confidence being able to get help without repercussions of fear. If the leadership is getting mental health help without any repercussions, then then the supervisees and the subordinates would feel more comfortable with also getting help. This lets subordinates become more comfortable talking about their own problems as well. If the leadership is talking about their problems, then the subordinates would follow. And this allows the subordinate to see talking about their feelings as good, as we talked about earlier with Skinner, with good and bad in a group control situation. Future directions of this proposal. A future direction of these ideas would actually be carrying them out. As of right now, they're still just ideas. This would be difficult because it means changing the way the leadership treats subordinates in general. So this would be a long-term change. It wouldn't happen overnight. And then another future direction is to provide reinforcements for those that do step forward and seek help. This would show that things aren't being taken away from them. They're not losing their jobs. They're not losing the control over what they do for a living. They're not having any repercussions that they fear, but they're actually being reinforced for getting the help that they need. So, limitations. The proposed methods require a change in what insurance accepts, and mainly with the finding their own therapist. And this would, like I said earlier, this would take a long time to become effective and to create a culture that mental health help is accepted instead of ridiculed. And then here are my references. Thank you for listening to my presentation today. I hope you have a good break. Bye!